So I'll stand here. Everybody can hear me okay? Great. So I too am going to take a step back and reflect on the sort of journey that we have been on, because I was there in that first meeting that Jeff alluded to this morning, when we sat with the Bipartisan Policy Center and the National Academy of Medicine and us from the Harvard School of Public Health and said, how do we do this together? And thinking about that journey from where we were 18, actually now probably closer to 2 years ago, to where we have come, I think we have made enormous progress. We, I think, identified today all of the challenges for moving forward, and those are completely appropriate. But I think it's worth taking a moment, because this is our third and final get-together, to reflect on how much progress we have made. And some things that feel very obvious and easy now didn't feel that way, at least it wasn't in my mind so obvious and easy when we began. So when we began this work and we started thinking about segmentation of high-cost, high-need patients, we really did see it through a clinical lens. We thought about it as, okay, these are patients who have different clinical needs. These are patients with different chronic diseases. These are patients with different types of health problems. That's what we want to segment out, because we're going to try to design clinical interventions that are going to target them. What have we learned in the last 18 months? We have learned the very, very important role of functional status. We have, through claims data, the much maligned claims data, actually figured out that you can use claims data to get some progress on functional status. Perfect? No. Good? I think so. And we have learned that functional status has very specific implications for spending. Of course, all of us could have predicted that people who have functional impairment are going to end up potentially spending more on healthcare. That's not that interesting. It's predictable. I think we have learned that there are very specific types of healthcare spending that get generated when people have functional impairment. And that begins to help us think about how to target that population and do something useful. I think we have learned about the key role of behavioral health in a way that I did not appreciate 18 months ago. Again, if you had asked me, is it behavioral health important? I would have said, of course. But I think we have learned that it actually is not an additive, it's not a multiplicative, it's a game changer in how these other diseases interact with spending and outcomes. And then in a very similar way, I think we have learned the very key role of socioeconomic status, other kind of key factors of what's going on at home, what's going on in the community, that I think we just didn't appreciate. And now we can look at all of that and say that's all really important and it's obvious. I'm going to be honest, at least for me, 18 to 24 months ago, it wasn't obvious. I could have predicted that they were important, but how they were important, how you measure it, what implications it has, I think we have really gotten that in the last 18 to 24 months. Thinking about the idea behind this was segment first, care models, align them together, voila, right? That's going to be the magic sauce. So let's talk a little bit about what we've learned about care models, or at least what I have learned in the last 18 months. And some of it got summarized today, so this is a little bit of what you heard already today. But I think we've learned that there are some care models out there that really do work, whether they focus on really bolstering primary care, whether they focus on strengthening transitions of care, whether they focus on integrating behavioral health and social factors. They really do work. They are out there. They have been successful. When you dig in at one level below, you find out that they are successful because they do a good job of targeting. They do a good job of engaging patients. They're terrific at care coordination. They have a multifaceted approach. There's a whole series of things you heard earlier from Arnie and others. But the bottom line is that there are features of these programs that we know really work. So we can segment. There are programs. So what's the difficulty? One of the difficulties is the matching process. This is enormously difficult, right? We don't know which of these models work for which patients reliably. And that's a real challenge. The other big thing we don't know is something that I'm going to describe as sort of thresholds. I got this idea a little bit from my buddy Prabjot saying. The idea of thresholds is this. We know that being a frail, older person is a huge risk factor for spending more, for having worse health outcomes. So when you begin to target, does that mean you target everybody who's frail and older? Majority of people who are frail and elderly do fine. And so what's the threshold you use to to enroll them in a program that's going to employ enormous amount of resources to keep them healthy and keep them well. If you get that threshold wrong, you will spend lots of money on people who were otherwise just going to do fine. And if you get that threshold wrong in the other direction, you're going to take a people who end up being very expensive, suffer from a lot of morbidity and mortality, and not target them and not deal with their issues at all. So getting that threshold right is incredibly important and incredibly hard. Last thing is that as you look at these matching programs and these efforts, one of the things you learn is that the best programs, some of the most successful ones, change over time. They begin in a certain way, they identify their population, they get going, they realize, actually, our target was a little bit off, we're going to make these following changes, we're going to change the way we're going to do these programs. That leads to a lot of difficulty when you then take that and say, I'm going to scale it. What are you going to scale? The original program, the change was a response to something very specific on the ground. These are real challenges, and I'm going to come back and finish with what I think are some of the challenges around spreading and scaling. But I think that's been one of the characteristics of the successful programs that's very difficult to scale. All right, I have 6 points. I've covered 3, so let me make the last 3. One of the other things I think we have learned is the importance of what happens outside the ecosystem. So we've been talking about patients and programs within the system. I think we heard a lot about the importance of integrating social support. Sounds great. It is almost always a good thing to do for patients themselves. Patients have better experience, are more satisfied, often have better outcomes. The data on whether these things actually save money, I think, is really not very good. You heard a little bit about how Europe spends twice, maybe 3 times as much on social services. They spend half as much on healthcare. 2 points on that. One is because Europe is not a country, there is immense variation within Europe in terms of how they manage these things. And second is that the causal relationship here is not so easy to nail down. And so the question is it because they spend all this extra money on social spending that are they keeping people healthy? And that's a very tempting argument. But I think in order to convince policymakers that we should be spending a lot more money on social services, I think we need much better data. And even if you could convince people of that, the problem somebody highlighted earlier, the issue around pots of money becomes very important. If you think the healthcare system is fragmented within itself, now we want to integrate the healthcare system, which is highly fragmented, with the social service system, which is highly fragmented, and get all of it integrated. It becomes a whole different level of complexity. It is not to suggest we shouldn't try it. There are some interesting experiments happening with this, including actually in places in Europe, for instance. Manchester in the United Kingdom is doing a very interesting experiment of kind of what's called devolution, of taking NHS money, social services money, putting it all into one big pot and saying, can we really improve the health and outcomes and the spending for an entire population if we put all the money into one pot? We have to look at those things, I think, very closely, understand what works and what doesn't. Last point on the kind of outside the ecosystem issue, I think the payment system underlying our healthcare delivery system is moving in the right direction, right? Medicare Advantage, ACOs, these are setting up the incentives for providers to make these kinds of investments. And if we don't see these kinds of investments, we don't see the kinds of investments in social services, I think we're going to have to ask ourselves, why not? If spending on housing saves enough money on healthcare, you would think ACOs would begin to do that. Because if they can then lower healthcare spending on the healthcare dollars, they would actually get to recoup some of those benefits. We have begun, I think, to get the financial incentives right. We're going to have to watch very closely where these organizations go in terms of whether they're going to make the investments in social services that we all think they will. If they don't, that is important evidence. Either they don't believe it or they don't know how to do it. Right? So I think we're going to have to pay close attention to that. Last couple of points. One is around quality measures. I don't know if is Joanne. Joanne is still there. Joanne and I had a sort of pleasure to write a piece with her in JAMA. It was mostly her idea. I just sort of tagged along. But one of the arguments that she made in that piece we made together was that the standard approaches to measuring quality easily can end up doing more harm than good for this population. For high-need, high-cost patients, the sort of evidence-based measures are usually derived from a population that is not this population. And so taking somebody who's frail, taking somebody who's an elder with 4 chronic diseases and a very complex home life and saying, I'm really going to work on getting your hemoglobin to 7, may end up doing more harm than good. You can easily imagine why that would do more harm than good, right? So we do, I think we all got it today. We do have to think about alternative approaches to measuring quality. I'll be the like 9th person to say this, but I'll say it because I don't think it can be said enough. We have to begin to measure what matters. Turns out what matters to you is different than what matters to me. And that means we have to elicit this stuff from patients themselves. And that means, and I think you heard this from a couple of folks, including Helen, Burstyn, driving towards more patient-reported outcomes. I think we have been saying this for years. This is just going way too slow. I think we need a lot more. And this is, look, I know it's difficult, but we're spending $3 trillion a year in healthcare. It is hard for me to think that, like, we can't measure patient-reported outcomes. It's too expensive. It's too complicated. It's a little bit complicated. It might cost millions. But in a $3 trillion healthcare system, we should be able to, I think, figure this out. Functional status, quality of life, this is the stuff I think that's going to be very important. Patient experience. And then when we go back to the segmentation stuff, one of the things I think we're going to learn is that what quality measures matter not only varies by patient, it varies by segment, it varies by subpopulations. And so we're going to have to take a very flexible approach to quality measurement. It's not just we're going to replace one set with a different set. I think we're going to have to think about quality measures very differently. All right, finishing off with kind of what I think are the big challenges moving ahead and what I heard as I talked to people today. The big challenge, of course, is if we have models, yes, we've got to get the payment system right, but I think we're making progress. Yes, we have to get the quality measures right, but I think we're making progress. The big challenge is how do you spread and scale? Somebody brought up the point earlier, which I really liked, which is where is it incubated and where is it implemented matters a lot. We have seen great models of healthcare delivery really struggle with scaling, as I often like to say. Kaiser Permanente, which is a great delivery system, can't figure out how to replicate Kaiser Permanente, right? They've struggled with broad expansion. If Kaiser can't figure out how to replicate Kaiser, it's not really clear that anybody else can figure out how to replicate Kaiser. These things are fundamentally very, very difficult. One of the things that drives great programs is leadership. One of the things that we often then turn to is say, well, if we just had great leadership everywhere, and barring like big gains in cloning technology, I think we're going to have to come up with a different model. We're not going to be able to take the great leader who did it here, clone them, get them to go and do it somewhere else. It is going to be about learning from the context. It is going to be about figuring out, well, what can you replicate, what can you not, and how do you then take what is essential and move it forward. I think there are a couple of other things that I just want to finish off with. I think we have to develop things that we can do to help that process. I think we can develop tools for organizations that want to do these things but don't know whether they're ready, what they're capable of. I think that's a very concrete thing I heard from several people that could be useful. Last point I want to make is over and over again today we heard about this idea of the ROI and what's the ROI and how quickly can we achieve it. I think we have to be realistic about how long it takes to get this stuff done, right? And the example I often use is if you take a look at Silicon Valley and startups, at best, 10 to 20% of them will ever make any money. And that's probably a very optimistic number. If you take a company that has been wildly successful, Google, it took them about 8-9 years to become profitable, okay? We do these things where we take these very complicated sick patients and say, we're going to change the way we deliver healthcare for these people, and we're going to save money. And 2 years later, it hasn't saved money, and we say, this is not working. I think we have to have different timelines because we're in a brand new frontier. We have practiced medicine in a certain way for 100+ years. It's really simple. Somebody got sick. They came to see me as a doctor. I took care of them. I sent them home. That was the model. It worked fine for 100 years. We're in a new era where we're going to have to practice medicine in a completely different way. And the idea that we're going to develop that new set of models and they're going to pay for themselves in 2 years or 3 years, I think we're going to be disappointed. So I want to see more experimentation, longer timelines, but it's the only way to go because the model of the last 100 years is not going to serve us well for the next 100. So I think under Peter's leadership, Jeff bringing us all together, Michael, Catherine from BPC. This has, I think, been an amazing 18 months. The work is just getting started, but I think we have to understand that we're on a quest that is fundamentally difficult, fundamentally important, and I think we've made a lot of progress. Thank you.